Hi, everyone. It's a concerned Dr. Miskoff, and it's August 2nd, 2020. Vlogging tonight on the continued story of immune system immunology and COVID-19. There was an article that was sent to me earlier today. This was by Dr. Sanjay Gupta and Andrea Kane. Actually, a very nice read and sort of goes through Immunology 101 on the vlog the other day. I discussed the T cell immunity, those T cell reactivity and regards to the Nature article, which Dr. Gupta is also referencing here. This was interesting because it showed probable cross-reactivity with previous coronaviruses and how when they looked at patients who had recovered from COVID, and I guess were giving convalescent plasma, donating, they were able to find obviously reactive T cells in over 80% of those who had recovered from COVID. Even though healthy donors that they went back a few years on, so they clearly didn't have the novel coronavirus, but could have had more common variants of the coronavirus. As we know, there's several others, and about a third of those patients had probable cross-reactivity and to the reactive T cells of COVID-2 or COVID-19. So that was interesting, and its implications for possible vaccines we'll talk about in a second. Remember that the immune system has both a innate immune system, and the B cell, white cell line is the first line of defense. We talked about the T cells the other day, but Sanjay does a nice, Dr. Gupta does a nice review of the B cells as well, and how on the cell surface there are immunoglobulins. So the whole IgG, when you're testing people for immunoglobulins, that's in really relation to this more first line of defense or IgG antibodies. We are finding, at least in the qualitative tests that have been FDA approved, that they are going negative after several months, especially those patients who probably had asymptomatic or milder disease. So there are patients that we're finding in people that were antibody positive. A lot of them, most of them were not admitted to the hospitals or with mild disease or were healthcare providers, and now a few months later are antibody negative. Now it's a qualitative test. The FDA recently approved a quantifiable test, or at least a semi-quantitative test. So it doesn't give you the exact precise measurement, but gives you an estimate, at least, of the quantity of antibody in the bloodstream when tested. And this may be more sensitive, or at least have a better predictive value. But they go through the B cell immunity. Again, there's an antigen that's presented, whether that be a bacterial antigen in this diagram, a viral antigen as in COVID, it could be a fungal antigen, or just any foreign body, parasite, etc. The B cell are that first line of defense, those mucosal barriers in the eyes, in the nasal passage, lungs, and the mouth, oral cavity. We haven't, fortunately, seen any cases of COVID-19, thank goodness, at least documented through the oral route, and that would make sense because I think a lot more people would be positive if you could just get it from passing it easily, from food products, let's say. But we do think respiratory droplets is number one, of course, but rubbing the eyes, if you potentially had live virus on your fingers or another fomite, could potentially be an issue. Remember, there is this line of defense. They do go through that. Remember the T cell, a little bit more complicated looking here. You have a diagram of SARS-CoV-2 coming in. The antigen is presented to a antigen presenting cell, in this case a dendritic cell, and that presents it to both that CD4 helper or that CD8 killer or cytotoxic cell. If it goes this way, and this is the second line of defense, if you will, but if it goes this way, then it could just get knocked out or destroyed. If it's going to the helper side, remember the CD4 helper actually can cause inflammatory cytokine release, CD8 priming, and even B cell priming for that antibody to be secreted, right? So you have a T cell line that's actually helping out B cell priming, and again, also on the T cell CD8 side. So that's interesting. Remember the histocompatibility 2 molecule goes with the CD4, and the histocompatibility 1 goes with the CD8. So if your immune system is strong, then hopefully the B cell via the immunoglobulin will knock it out. The IgG is what's tested for right now in the qualitative. We have a quantitative test that was just FDA approved, semi-quantitative, which hopefully has a better result. I sort of lost some hope here with the qualitative test, so maybe the quantitative will resurface or will surface here and bring some new light to it. Um, so that's really the story with the immune system and B and T cell workings almost together. If again that first line doesn't work, you have your T cell line. There could be memory cells that are available, and again with the Nature article, is there memory from previous coronavirus and some cross-reactivity to give you immune benefit? Now, remember, having the previous coronaviruses, we don't know yet if that's absolutely beneficial. We think it may be, but it's possible that you could have a cytokine storm and that you could have these IL-6s and other cytokines really flare up. I think this is the basis behind why Decadron seems to be saving lives. I've mentioned budesonide or inhaled corticosteroids. To me, I don't see too much of a downside if you're a mild case, asymptomatic case, or just have mild symptoms or are found to have coronavirus with no symptoms. You probably just watch them, but if they have any symptoms at all pulmonary related, I do feel like giving the inhaled steroid. If your immune system's strong enough, this should just go away. If it isn't strong enough, then you go into a cytokine storm and you're going to need the steroids anyway. What dose of Decadron? 6 milligrams for 10 days is the inpatient regimen. Whether we'll be using that exact same dosing or even going lower, I think time will tell, and hopefully we'll have more studies to help us with that. Okay, so for now, I'd like to thank everybody, and that was the immune system wrap up. I think in the next vlog, we'll revisit melatonin. That seemed to be the vlog that got the most attention so far, with over 7,000 hits, just discussing melatonin and the clinicaltrial.gov and ongoing trials. I think there was 4 or 5 of them I saw. So we'll discuss that in the next vlog, and whether prophylaxis. We talked about prophylaxis with hydroxychloroquine and how I'd like to see a healthcare provider or people that are exposed or high risk patients, I should say, of getting exposed, whether that be a cashier in a supermarket or cleaning services in a hospital, not just the providers treating, but those other positions and jobs that may have as high exposure, if not higher exposure than healthcare providers front line. There was a recent article that suggested that healthcare providers are at a higher risk of getting it. The real question will be is, did those healthcare providers have previous coronaviruses that gave them cross-reactivity and immunity? Okay, everybody have a great night, and thanks for joining.